Good evening, everyone. Welcome you all for the IPNA endorsed Webmaster Series 2021. Now we have landed into webinar 15, and sorry for the delay in the webinar series. There were some technical issues. Sorry for the delay. So today we have two eminent speakers, Dr. Bagga and Dr. Minnie Sarwal, who doesn't require any introduction. So the first talk will be done by Dr. Bagga. Dr. Bagga is he's a professor, head of Department of Pediatrics at All India Institute of Medical Sciences, New Delhi, and his interest is towards glomerular disease, and he is also a recipient of IPNA Educational Award for the year 2019, and he is also received Academy Oration by National Academy of Medical Sciences in the year 2017, and he has also received Namalvar Oration by Indian Society of Pediatric Nephrology for the year 2016. Over to Dr. Bagga to deliver his talk on hemolytic uremic syndrome. Over to you, sir.
Thank you, Kalevani. Thank you, Dr. Namalvar and Dr. Kalevani and the Mehta Children's Hospital for this opportunity to speak to you. Can you hear me, Kalevani, clearly? Am I audible?
I can hear you, sir. It's clear.
Okay. So, today we'll talk to you about hemolytic uremic syndrome, which you all know is a rare or ultra-rare thrombotic microangiopathy. And this slide shows that the incidence is something like 2 to 5 patients, children per 100,000 population, which is essentially the similar incidence as nephrotic syndrome. If you look at the worldwide data, but I think because the cases are acute, therefore one never, and nephrotic syndrome stays longer, it is a prevalent disease. So HUS, this is the incidence. Atypical HUS, which we will be covering in some detail today, has an incidence that is almost 1/10 that of all HUS. So the majority of HUS that we see or encounter worldwide is non-atypical really. Now, what is thrombotic microangiopathy? Thrombotic microangiopathy is really the combination of the presence of microangiopathic hemolytic anemia as observed by finding schistocytes in the peripheral smear, thrombocytopenia, and acute kidney injury. And this could happen in adults typically with thrombotic thrombocytopenic purpura, as is shown here on the left, either due to a congenital deficiency of ADAMTS 13 or more commonly due to anti-ADAMTS 13 autoantibodies. That's far more commoner than congenital deficiency. So that's one group, which you'd pick up by looking at the ADAMTS 13 activity. But the other large group that we see more often in children is the group with hemolytic uremic syndrome. And if you look at hemolytic uremic syndrome, the maroon star shows that the commonest cause of hemolytic uremic syndrome are the infection-related HUS. Most typically, the sugar toxin associated HUS. Then you have the pneumococcal HUS. There's a group of secondary HUS that is on the top square, which can happen with a variety of disorders like lupus, malignancy, certain drugs, and so on. But also, certain infections may trigger HUS. We do know, that in India, Plasmodium vivax has often been associated with the hemolytic uremic syndrome kind of a picture, as have other infections. And more recently, so, at least in North India, we have been seeing more patients with the HUS following SARS-CoV-2 infection. And this has already been reported in KI reports from other centers of single case reports, but we are also seeing patients who have anti-FH associated relapses of infection following SARS-CoV-2 infection. The cobalamin C defect is an uncommon condition, but below the red line that you can see here, the dotted red line or the dotted maroon line, is the group of disorders that we call atypical HUS. And atypical HUS, the way we understand today, is really a conglomeration of or a group of disorders that have it together. The basis is really a disorder of the complement pathway and rarely the coagulation pathway. So you have problems with the standard alternative complement pathway regulation, mutations in various genes. I'm sure you've heard about these genes, or anti-FH antibodies, and we'll be talking about each of these conditions subsequently. DGKE is a condition. DGKE mutations are relatively unique to children, uncommon, but can present in a very, very characteristic manner. But even if you are able to find a cause in about 60% of patients with atypical HUS, in about 30%, we still don't know the cause. And we are still not sure, what exactly, but the assumption is that much of this is complement related, and these genes are waiting to be discovered and so on. Okay, so this slide really shows you the timeline, how HUS has evolved and what's our current understanding of this disease. We know that HUS was first described by Dr. Gasser in 5 children in 1955. And interestingly, this is the time around which the alternative pathway was also discovered, the alternative complement pathway, which seems to be so closely linked to HUS. We came to know that TTP was a different disorder, which was more in mid-60s. And then there were reports from Dhaka as well as from Vellore, wherein they showed that the classic HUS followed infections with Shigella. And but the exact mechanisms were not clear, but the first paper came from Dhaka and then Vellore. And subsequently, it was only in 1983, when I was joining as a resident, that we came to know that when Dr. Karmali showed that it's the Shiga toxin that's elaborated by E. coli that causes, that is the proximate cause for occurrence of hemolytic uremic syndrome. And this is the so-called the Shiga toxin associated HUS or the diarrheal HUS. And over the years, we have had various major discoveries. In 1998, it was first shown in a major way that complement system is directly linked to the occurrence of HUS. And here, this is the region of, and we'll be discussing about the RC as we go ahead. Dr. Dragan Dure is credited with the discovery of factor H antibodies about 15 years ago. And subsequently also, there have been multiple advances and more genes have been discovered that can really cause hemolytic uremic syndrome. Just as our understanding of the pathogenesis has gone on, similarly, the management has also changed, as you can see in the upper part of the slide. So beginning from conservative care, which still continues to be an important part in almost all HUS, then there was a time of exchange transfusions, then plasma exchanges, and now we have complement blockade. So about 4 years ago, the Indian Society of Pediatric Nephrology sat down to try to make consensus guidelines for hemolytic uremic syndrome. And when they were being designed, we were aware that we did not have access to a number of medications that were available all over the world. But then, so these guidelines are really, consensus guidelines for developing countries. This was published in Pediatric Nephrology. And those of you who have not read this article, I think people who are working in India, South Asia, should definitely be reading this. And we recommended that the diagnosis of HUS should be the standard way. So you document microangiopathic hemolytic anemia with histiocytes, demonstration of LDH and low haptoglobins, thrombocytopenia, remembering that a proportion of patients may not always have thrombocytopenia when they are discovered, acute kidney injury. We also recommended that we should evaluate for TTP if there is indication. Now, this is a controversial thing, because that ADAMTS assays are not easily available. And overall, there is a feeling that if you look at thrombotic microangiopathy in children, thrombotic thrombocytopenic purpura accounts for a small proportion, maybe less than 5% or 7%. So the current guidelines, and this is also what we recommended, was that only if you have got persistent thrombocytopenia and platelets below 30,000, should we be really worried about TTP. I'm not saying this is something that's cast in stone, but but at least in the developing countries where access to ADAMTS activity is not available, one of the important markers would be persistent thrombocytopenia. In settings like ours, we should always be excluding sepsis, also screening for malaria, leptospirosis, as well as dengue. Now, all these things could mimic HUS in a major way. And they could also, precipitate HUS. But be careful diagnosing HUS in the presence of sepsis. You can get a disseminated intravascular coagulation and all the features that of thrombotic microangiopathy. So I would never diagnose HUS in somebody who has got overt bacterial sepsis, except perhaps in a setting of pneumococcal HUS. Now, what are the diagnostic tests for diagnosing hemolytic uremic syndrome? The standard diagnosis would rely on a complete blood count, looking at broken cells on the peripheral smear, demonstrating reticulocytosis. LDH is an important and easily available test, but do remember that LDH could be elevated non-specifically with malaria, with dengue, and so on. So you really can't rely too much on LDH. Haptoglobin is a good test, if you have access, and if the haptoglobin levels are very low, then clearly it indicates intravascular hemolysis. One would do kidney function tests, examine the urine for protein and formed elements, and do serologies for malaria, dengue, leptospira, and now currently we would always do a serology for SARS-CoV-2 as well. Coagulation profile is usually not required unless you are suspecting a DIC, like picture. An ultrasound abdomen is obviously required if you have a child with acute kidney injury and you would want to get an ultrasound done to see if both the kidneys look normal. Echocardiography, neuroimaging, these are required only in specific instances. Now, once you have a diagnosis, then you need to figure out the cause, and we'll discuss these as we go along. But the important test that one would want to do is a serum complement level, at least in all patients. If you have a history of dysentery or there's been an epidemic of Shigella, then one need not do anti-FH levels, particularly in very young kids. But outside of that, and especially now, and we'll discuss this later as we go through, given that we don't see too much shigellosis, if you have a child with HUS, particularly who's, say, around 5 years of age, I would definitely advise an anti-FH level. You don't need to do anti-nuclear antibodies unless you're suspecting lupus. But again, if you have a child with atypical HUS, and we'll discuss this further, a flow cytometry for CD46 is perhaps essential. As I said, that we really can't do levels for ADAMTS routinely, but so we would recommend, and these are the guidelines, would recommend that we should store samples for ADAMTS 13 activity, as well as for homocysteine. And if you can't find a cause, go back to these samples later. If one is suspecting sugar toxin associated HUS, one would evaluate these patients with a stool culture, PCR for sugar toxin. Alternatively, one could look at anti-lipopolysaccharide antibodies in the blood. Now, these tests are again not commonly available, but in a patient who has dysentery or diarrhea with HUS, I think it's imperative to be able to do a stool culture and a PCR for sugar toxin in almost all patients. Interestingly, we don't see too much pneumococcal HUS, but I don't know what the experience in other parts of the country is. But by seeing so many patients of HUS, we don't seem to diagnose a definite pneumococcal HUS, but then the criteria for diagnosis are relatively clear. In addition, if you have a patient with with atypical HUS, it is almost imperative to be doing next-gen sequencing for the standard 6 or 7 genes. So if you're suspecting somebody has atypical HUS, we would be doing this through so we do a clinical exome sequencing for factor H, factor I, factor B, C3, CD46, DGKE in younger children, and the methylcobalamin gene if the setting is there. In addition, and we'll come to this later, but if you have a patient who has got Antifactor H antibodies, one should also have access to MLPA to look at copy number variations in CFHR125. Now, you will say, are these tests available in the country? Yes, they are. I think most metropolitan cities would have access to these tests. And definitely, if you've got a patient with atypical HUS, you do not have too many options, but to definitely be able to do a C3, anti-FH, to be able to do next-gen sequencing for the standard genes, do a flow cytometry for CD46, as well as MLPA. And the number of genes, that are involved in HUS seem to be rising, but the core genes are really listed on the left. So you have these 6 or 7 genes, and we'll discuss them as we go along. In addition, on the extreme right, you have a number of other genes, that have been incriminated, and there is enough evidence to say that these mutations in any of these genes could result in hemolytic uremic syndrome. So when you are sending for a gene panel, it would be important to send the whole gene panel to be looked at. So what is our usual schema? So our usual schema is that you've got a patient with suspected HUS as evidenced by thrombotic microangiopathy, seeing schistocytes on the smear, thrombocytopenia, acute kidney injury. One would definitely want to exclude sepsis clinically, or DIC, which again is a clinical diagnosis, evaluate for the routine tropical infections, including SARS-CoV-2 currently. If you have thrombocytopenia, then one should think about TTP. Otherwise, in pediatric practice, TTP is a relatively uncommon disease. It is still good to be able to store samples at -20 in sodium citrate for a later advanced certain activity should it be required. And if these two things are, so if TTP is excluded and all the tropical infections are excluded, then one would think about that this child probably has HUS. One would take a history of dysentery, either in the child or if there's been an outbreak, particularly in children who are above 6 months of age, and one would need to do the standard lab tests to be able to confirm the diagnosis. Again, cobalamin C deficiency is not as if it's totally, this could be the cause for HUS in about 5 to 7% of all children. And therefore, again, if you don't have ready access to homocysteine levels, again, one can store samples and come back to them later, if you don't find a cause on standard evaluation. So clearly for TTP and for homocysteine levels, one should have facilities to be able to store these samples. One should exclude conditions that can cause secondary HUS, and these are listed here: presence of lupus, the Apla syndrome, and so on. And if all these things are excluded, then you start thinking about atypical HUS. And as I said, at least the basic workup for atypical HUS would comprise of looking at complement levels, doing a flow cytometry for CD46, looking at Antifactor H autoantibodies, and planning for genetic screening by next-gen sequencing for the standard complement panel. And if you do get a positive report based on any of these, then you wonder that this is a complement-mediated HUS. Now, what about sugar toxin-associated HUS? Now, there has been a real change, the way, particularly in our country, while worldwide, sugar toxin-associated HUS is the commonest form of HUS. Clearly, in referral centers in the country, we do not seem to be seeing too much of this disease. And this has happened chiefly because our organism, that was chiefly responsible for sugar toxin-associated HUS was Shigella. And over the years, the circulation of Shigella isolates has clearly reduced. And clearly, Shigella dysentery has become extremely uncommon in most of South Asia and many parts of even Africa. So clearly, Shigella dysentery as an organism for causing sugar toxin-associated HUS has declined. Not to say that other Shigella cannot cause, but overall the proportion of shigellosis seems to be lower in our country. Less than 5% of all diarrheal diseases currently is due to shigellosis. So clearly this has declined, and therefore that's the reason we perhaps do not see so much dysentery. We don't see so much dysentery-associated HUS. Now, what about enterohemorrhagic E. coli? Now, enterohemorrhagic E. coli contaminate milk, we know, and therefore the normal route of transmission is through meat or contaminated milk, or more often vegetables like salads, etc. Interestingly, there's not too much data from our country also on EHEC. It's not that people have not been looking at it, particularly at PGI Chandigarh. Dr. Taneja has been looking at this very carefully. And while she does seem to see some patients off and on, overall, the proportion of EHEC as a factor, EHEC as such, in our community is limited. We do not have very strong data to say that EHEC is in circulation in a major way in the country, particularly in North India. And I'm sure that's also true about the other parts of the country. As far as EHEC are concerned, you have certain common species like the O157H7, which you are all aware of. At the other extreme, it was the O104H4 that caused the European epidemic. You are aware, about 10 years back, where you had large parts of Germany and major parts of Western Europe that were affected. But again, just to again emphasize that EHEC as such appears to be an uncommon problem with us. Now, once you get EHEC or sugar toxin infection, in a period of 5 to 7 days, something like 10% of all patients who get either EHEC or Shigella dysentery would get diarrhea or a dysenteric illness. The proportion would vary, and about 10% of these would then go on to develop HUS. During outbreaks, at times, in the European epidemic, they reported that almost 20% patients who got EHEC infection ended up getting HUS. But the overall figure is more like 6 to 9%, and maybe slightly higher with shigellosis. And once you get HUS, then you have the characteristic features of hemolytic uremic syndrome. To complicate this picture slightly more has been the recent evidence. In fact, it's not really recent, but evidence that the complement system also gets activated with Shiga toxin associated E. coli associated HUS. So there is enough evidence that the complement system is also involved in the pathogenesis of a STEC associated hemolytic uremic syndrome. Now, what do we know about therapy of Shiga toxin associated? What is new here really? There's nothing very much new except to say, that there is more and more evidence that's emerging from more like clinical case series that suggests that one should maintain hydration from the onset of bloody diarrhea to the onset of HUS. And there have been some reports, chiefly that came from Italy and thereafter from other parts of the world, that suggested that hydration with isotonic fluids was a good idea until AKI set in, obviously. Once you have AKI, then obviously you can't hydrate more. But by giving isotonic fluids, the risk of hemolytic uremic syndrome was clearly lower. And even our guidelines, we recommended it. We said that we recommend the use of isotonic fluids, either saline or ringer lactate, trying to maintain a positive balance in patients who have dysentery or bloody diarrhea until they get, once you get AKI, then you would stop giving IV fluids. What about the role of antibiotics? So there has been some controversy on this. There was some data that in patients with STEC HUS, particularly E. coli HUS, when you give antibiotics, there was a higher risk. But the overall consensus, and given the fact, that for us, shigellosis may still be important, our guidelines recommend, and you can see this is a 1A advice, that if you get the bloody diarrhea or dysentery, we would recommend the use of either cefixime or a fluoroquinolone for 3 to 5 days in order to prevent the occurrence of Shiga toxin associated HUS. We did not advise the use of plasma exchanges or eculizumab for this indication. Even the updated guidelines from the American Society for Apheresis, with the most recent guidelines are published in Journal of Clinical Apheresis 2019. They again do not suggest the routine use of apheresis for STEC HUS. There are some exceptions that are listed here. I'll skip this slide, but just to say, that there is more and more evidence that Shiga toxin HUS, one of the ways by which you can prevent its rating. Although, there is some data to the contrary that was just published, wherein they showed that in older children, adolescents, clearly the benefits were not there. So I think we still need an answer on this. Now, if you look at pediatric atypical HUS, the complement-mediated HUS, and this is really a table showing data from some large series. The first column is the data from Bachi from France. The other one is a pan-European data from Italy. And then the third one is from Dr. Schaefer's group. It was really a global HUS registry. And the last column is really data from adults. And as you can see, these are large numbers. But what these numbers say is that in atypical HUS, one is able to find a cause that is either a mutation in the standard complement genes or autoantibodies in almost 60% of all patients. This can be, from between 45 to 60, but almost 2/3 of all patients would show either a mutation or an antibody if they are evaluated carefully. In about 30 to 40%, you may not find a cause. So one should be aware that one may not find a cause. And the overall breakup, if you look at children or in adults, is almost similar. And the three commonest causes that really stand out worldwide are mutations in the CF complement factor H gene, the CD46, or the macrophage, or the MCP. CFI, C3 are lower, but Antifactor H antibodies is clearly, an important cause for atypical HUS, particularly in children. Even in Dr. Schaefer's global HUS registry, almost 45% of the 6 to 17-year-olds had antibodies. And as has been and we'll talk about our experience now. Apart from the standard ones, there is a reasonable genotype-phenotype correlation, and one can usually, at least have a educated guess as to the likely cause. It's not, you still need to do genetics though, but if you have very young children, one would think about factor H, factor I, factor B, etc. Older children, particularly in children who are between 5 to 15 years, one would suspect antifactor H autoantibodies. If you have DGK, diacylglycerol kinase epsilon mutations, you may get an MPGN-like lesion, but typically happening in kids who are below 2 years of age. Relapses are frequent with the CD46 mutations. But interestingly, the likelihood of these patients going on to end-stage kidney disease is low. The risk of graft recurrence also relies on the underlying cause. So with factor H, factor I, and with the C3 mutation, the risk of graft recurrence is clearly high compared to mutations with, say, CD46 or even antifactor H antibody. So depending on the clinical presentation at the age when they present, whether they are having relapses and so on, one can infer, but you still need to do genetics. Now, what is the therapy for atypical HUS? Till now, and till almost 10 years ago, standard therapy for atypical HUS has been the use of plasma exchanges. For us, even today, the prime therapy for atypical HUS would be the use of plasma exchanges. But this single Kaplan-Meier, really shows the outcomes as to what happens when you do plasma exchanges alone. And if you look at this data, based on data from Italy as well as from France, on a very large number of children as well as adults, you can see, that while children do slightly better, but even at the end of 5-year follow-up, almost 45% of children and almost 70% of adults would be at end-stage renal failure or end-stage kidney failure, or they would have succumbed to the illness. So more than 50% patients at the end of 5-year follow-up with plasma exchanges alone do not have a good outcome. And that's something, that we need to be aware that if you have atypical HUS, then PEX is what we have currently, but it's not the best form of therapy. What has changed the therapy has been the availability of complement blockade. And typically, the terminal complement blockade using eculizumab and its other modifications. And clearly, the outcomes are far better when you are using eculizumab or eculizumab. The overall outcome is that more than 85% patients show good outcomes. And so do remember this figure of less than 15%. So about 10 to 15% go on to kidney failure. So clearly this single drug, that has been available has changed the outcomes. And there is data, that the earlier you begin therapy, the better are the outcomes. And the outcomes are even apart from the kidney and the bone marrow, and blood. The outcomes as far as neurological features are concerned, cardiac outcomes are concerned, are clearly superior. Our problem is that there is a lack of access to this medication. So if you look at this, various guidelines from various countries across the world, if you look at prior to 2010, when eculizumab was not available, the prime therapy, as advised, say, by Dr. Erisita from Italy, from Spain, or the UK guidelines, they were advising the use of plasma exchanges. But once eculizumab became available, as you can see in this chart on the extreme right column, it has become the first-line therapy for managing patients with atypical HUS. If you look at data, if you look at guidelines from Japan, Spain, Korea, and what all, the consensus IPNA guidelines, and even the KDIGO guidelines, they suggested that one should be using eculizumab for atypical HUS. The only exception perhaps is that if you've got antifactor H disease, so there one could prefer using plasma exchanges, because there you could remove the antifactor H antibodies, and therefore clearly most of these guidelines were still having this caveat or the flexibility of, I don't use the word caveat, the flexibility to use plasma exchanges in patients with autoantibodies. The IPNA, there is a plan to have recent IPNA guide, which should probably be coming up, by 2022. But you're aware, that our problem has been the access to eculizumab, and clearly in most developing countries, there is limited access. In fact, there is no access. So clearly, for us, the major form of therapy would still be plasma exchanges. And we just published about 2 years ago our experience with the plasma exchanges, almost 2,000 odd episodes, 2,000 odd procedures published in the Journal of Clinical Apheresis, wherein we showed, that in the right hands, probably the risks are not too many. We still have filter reactions, there are problems, but it's not something, that we really, given that we don't have access to eculizumab, and if you have experience with plasma exchanges, it's still a useful form of therapy. The Cochrane Database Systematic Review just published its update on interventions for atypical HUS. And they published data from 5 studies, 4 based on eculizumab, and 1 based on revolutimab. And these are all single-arm studies with a high risk of bias. But all 3 studies are saying is that if you are using eculizumab or revolutimab incidentally is a longer-acting C5 inhibitor, which needs to be dosed something like 8 weekly. In younger children, below the weight of 20 kgs, perhaps you need to dose it 4 weekly, but overall it's a 8 weekly dosing compared to eculizumab, which requires 2 to 3 weekly dosing. But whether you use either of these 2 agents, clearly, the outcomes were far superior. And there was a complete TMA response in a very large proportion. So clearly the benefits of terminal complement blockade are there to see. They had some serious adverse events, and there is clearly a small risk of meningococcal infections, and which requires immunization and so on. We won't go into details on this. The moot question has been, and I think it's relevant again because it's just an issue of time before you get complement inhibitors even in our country. Once you start eculizumab, can you stop eculizumab? Initially, when eculizumab came, it was said that, no, it's a lifelong therapy, and it's obviously out of bounds for all of us, But there is data, emerging, and there are these 2 trials that were both published earlier this year, one in Blood, the other in Blood Advances, that seem to suggest, that while you use eculizumab, and you can, and if a patient is showing stable kidney function, and if a patient is in hemat remission, one could consider stopping after a variable period of time, and thereafter monitor these patients for relapse. And if you relapse, one can always go back to eculizumab therapy. So if you look at the first trial, they had about 55 odd patients with atypical HUS, wherein they stopped eculizumab after a year. The patients who had variants, the ones who had mutations in the standard genes, they had a higher risk of relapses. But the good thing is that even if they relapsed, one could resume C5 inhibition, and they would again go back, they would again achieve remission. So clearly, salvage is possible. So it's not as if you lose everything, provided you are monitoring for relapses. One other marker that could indicate, that you may not be able to stop is the presence of high soluble CMAC or high soluble C5b9. So patients who have got high soluble C5b9, one should be careful stopping. And the same data has come from US, where again they showed that one could stop therapy after a few months. And even if you relapse, successful salvage is possible. So if the drug does become available after a while, there could be a feasibility of considering stopping therapy, So it may not be that expensive overall, particularly if the cost was to decline. And we'll discuss this maybe now and maybe when we take questions. Okay. The next few slides really talk about. Yeah, I changed the slides, but it probably has still the old set came up, but it's okay, don't worry. Interestingly, if you look at data from our country, about 50% of all atypical HUS is due to Antifactor H autoantibodies, and I'm sure you're all aware about this data. And we became interested in atypical HUS, because we were running some kind of complement service that began, about 15 years ago. And over the last 15 years, we have accrued we have close to about 1,000 patients from all over the country, as you can see on the map on the right-hand side. And interestingly, about 55 to 57% of patients have consistently shown Antifactor H autoantibodies. And if you compare this to the data from the rest of the world, the data there really was something like 25% or 15%. So clearly, we have a higher proportion of patients who have Antifactor H autoantibodies. Most of these autoantibodies are IgG3, and they're in fact, once we isotyped them, they were all IgG3. We have not shown IgA, but other people have shown that at times, IgA antibodies may also be there. And interestingly, 85% of patients who have antifactor H autoantibodies have a deletion of the CFHR1 gene. There was a slide that I had, but probably I won't be able to show that now. But the CFHR1 gene is really in the RCA cluster, the regulators of complement activation cluster, on the long arm of chromosome 1, close to CFH. And because of recombinations, you can have problems and you can have deletions of CFHR1, CFHR3, and the majority of patients, as is shown here, who have antifactor H autoantibodies, would show a deletion of CFHR1. There is a recent paper in JASN that showed that IgM antibodies are also known to be there. About 4% of patients may show anti-IgM antibodies, although the ones with the anti-IgM antibodies did not show the relationship to CFHR1 deletion. If one looks at the phenotype of these patients, the phenotype is almost identical to all forms of atypical HUS. There's no difference. This table really shows you that patients would have the classic triad in almost all the patients. Interestingly, India has the largest numbers, because we have been collating this data over the last, say, 10 years. And but if you look at the first row, almost 20% of patients may have a diarrheal prodrome. So don't feel, that diarrhea means sugar toxin. If there is dysentery, clearly, one has to be worried, but diarrhea could very well be a prodrome or even an infectious prodrome. In fact, virtually almost all our patients, would either have a diarrheal prodrome or a history of fever, abdominal pain, and some pallor before the onset of illness. A large majority of them would require dialysis, and then they would have extrarenal manifestations as well. Relapses can occur in about 20% of patients, typically within 2 years of onset, and we'll come to this again, but this is an important feature. And what we also seem to understand now, and there is data from even our lab, that anti-factor B antibodies may also be associated in some patients, but this is still early data. We've also shown that because this antibody is IgG, therefore, doing plasmapheresis leads to a rapid decline. So just 5 to 7 plasma exchanges would lead to a reduction of antibodies by almost 80 to 85%, as is seen here. Because being an IgG antibody, it's chiefly in the intravascular compartment. And as you can see, just 5 exchanges would lead to a total depletion, as you see on the figure on the right-hand side. But as I said, that about 20% patients may relapse, chiefly within the first 2 years, and therefore one has to be aware and always be on the lookout, particularly in children who are having infectious illnesses. One of the tools, which again is there's only one paper published in Journal of Nephrology this year, that the presence of hemoglobinuria may be an early marker of relapse. And therefore, if you have got a child who's got antifactor H disease or even atypical HUS, if your patient does get a URI, or one can teach the parents, to be able to examine the urine for blood. And this could be an early marker of a impending relapse, so that you don't have to wait before anemia sets in and so on. Okay. What we also showed, in our large nationwide series is that the therapy of antifactor H autoantibodies really comprises plasma exchanges with immunosuppression. So it's a combination that improves outcomes. And as you can see in the left Kaplan-Meier, the best outcomes were seen in patients who received induction immunosuppression along with plasma exchanges. If you do not do plasma exchanges, the outcomes are inferior. And if you just rely on plasma exchanges, the outcomes are also not very good. So you really need to combine the two for best outcomes. And this is on reasonably large number of subjects. And the right Kaplan-Meier shows that the continuation of immunosuppression does prevent relapses. And as you can see, that patients who received maintenance immunosuppression over a period of the next 5 years, they clearly had less relapses than the ones who were not receiving immunosuppression. The overall outcomes of antifactor H HUS seem to be improving, but they are still, not as good. If one cannot accept. So if you look again, remember that 15% figure of eculizumab despite doing whatever we are doing, still about 30% of patients would end up in CKD stage 4-5, or they would succumb to the illness. So clearly this is still a very large number, and we need to have better therapies. At the moment, PEX immunosuppression seems to be the best we have, and it appears, that our outcomes are also getting better. But clearly, the about quarter of all patients would go on to CKD 4-5, or they may die. And as I said, the relapse rates are about 20%. This is our current protocol. I'm sure you're all aware. I won't spend too much time on this. It's really a combination of plasma exchanges that are initiated every day initially, and then, thrice a week, and then twice a week. It appears, that maybe slightly abbreviated protocols would do as well. And currently, we are doing a trial wherein we are trying to cut down on the number of plasma exchanges. I don't think plasma infusion is as good. Clearly, I don't think, because they would not remove the autoantibodies. Then you have some induction therapy, and thereafter, you would continue with maintenance therapy with prednisone and mycophenolate for a period of time, and as well as monitor antifactor H levels. One question, that's often asked is that if you get antifactor H autoantibodies, do you also require exome sequencing? If you look at data, that's there from the literature, and this is data from our center when Dr. Priyanka was doing a DM, and she was able to do clinical exome in almost 100 odd patients. So we have data from almost 300 patients worldwide. The overall picking up of a genetic mutation is close to 6%. So if you've got antifactor H disease, then most likely you do not need to look at other genes. You don't need to do a clinical exome sequencing to try to pick up other genes. I did tell you that 85% would have a deletion of the CFHR1, but that's different. But you don't need to look at CFH, CFI, and so on. However, if you've got very early onset of disease, or if you've got relapses, multiple relapses, or a family history, and so on, then what one would typically advise doing antifactor H, then one would do genetics for antifactor H. A number of other drugs are being examined. I won't take too much time here. We can take this during questions, but clearly the last line, the iptacopan, which is a factor B inhibitor, is an oral agent that's going to start trials in India now. Very soon, maybe in the next 3 months, they're going to be starting adult trials. So I think that would be something that we are looking forward to, and the benefit would be that this is an oral drug. And clearly, there are trials happening with eculizumab, revolizumab, and even crovalimab, which again is a eculizumab-like drug. And as the Eclustex and Eculishu are looking at the role of eculizumab in Shiga toxin-associated HUS, and so on. We'll leave this, maybe we are probably falling short of time, and so I'll just end with again talking to you about the algorithm that I had initially talked to you about, So when you suspect HUS, always think about sepsis, malaria, dengue, leptospirosis, which can mimic HUS. Keep that first in mind. Do not diagnose HUS in a child who is clinically septic and having DIC. TTP is uncommon in children. But if you have thrombocytopenia, take samples for ADAMS13, try to get these activity done. Cobalamin C is also less common, but again, one should have access to homocysteine levels. If you can't have access, at least store the samples somewhere. One should evaluate for Shiga toxin-associated HUS, particularly if there's a history of dysentery. I know that we do not have access to PCRs routinely, but they are getting more and more available. And if all these are excluded, then think about atypical HUS. But the tests that I've listed for atypical HUS, I think it's imperative that these tests be done. So you need to do C3, you need to do flow cytometry for CD46. There has to be antifactor H screening, and you have to have a genetic screening. And these samples should be taken before you start plasma exchanges. So please don't start plasma exchanges before taking an antifactor H level. Because as I showed to you, with 3 plasma exchanges, the antifactor H level is going to decline by 80%. Once we get samples, with 6 plasma exchange ho chuke hain, it's quite late by then, So it have to be done before that. I know the genetics would not alter with plasma exchanges, but at least, we should have, and these tests are all available. So I'll stop here and maybe take questions. Thank you, Kalaivani, for the opportunity to speak.
Thank you, sir. Thank you for the wonderful presentation. It's actually nice to listen to great teachers, as they are the people who actually drill the subject into our minds.
I can't hear you
And
well.
I'm sure Bagga sir is not an exception to this. It was an excellent talk. We'll move on to the next speaker, Dr. Minnie Sarwal. Sarwal, ma'am, you're there around?
Yes.
Can't hear you. At least I can't hear you. Yeah.
Yes, I'm
Sarwal,
here.
ma'am, you're able to hear me?
I'm able to hear you.
Yeah, like
No, I
Dr.
can't
Sarwal does
hear.
not require any introduction. She is a professor in residence surgery division of multi-organ transplantation.
Sorry, yeah.
And she is also a professor of medicine,
Just coming
pediatrics
bits.
at USCF. She is a medical director of kidney pancreas transplant program, and she is also a director of precision transplant medicine of Sarwal Labs. And her academic interest is towards immunobiology of organ dysfunction, drug repositioning, and genomics, proteomics, and immunosuppression personalization. She is a recipient of multiple awards, and she is also a principal investigator for many of the clinical trials. Over to Dr. Sarwal, ma'am, to deliver a talk. You're able
Thank
to
you
see
so
yourself.
much. Yes, thank you so much for this invitation, giving this talk from California, and really delighted to actually present. The requested talk title was to optimize immunosuppression for the pediatric patient. Am I able to move my own slides? Yes.
Yeah, you're able to.
Okay, perfect. These are my disclosures. So immunosuppression problems for the pediatric transplant patients, I think the biggest issue that faces us as clinicians is that our patients have many immunosuppression choices. And these immunosuppression drugs, of course, are associated with a lot of toxicities, such as we're familiar, the most important toxicity for our patients is one of growth suppression relating to maintenance steroid therapy. There's also calcineurin inhibitor toxicity, which can result in a progressive interstitial fibrosis and tubular atrophy, and potentially premature graft loss. The mTORs can actually have toxicity, such as the problems of potentially reducing sperm counts, and especially this could be important in a young male child that is actually still pre-pubertal. There's also the burden of chronic immunosuppression, such as more viral infections, as of course, as we know, most of our pediatric patients are immunologically naive. As a result, because of being EBV negative and most pediatric patients receiving either EBV positive donors or then getting EBV infection after transplantation, this could actually also increases their risk of post-transplant lymphoproliferative disorder. There's also variable immunosuppressive drug handling in the young child. The bioavailabilities of these drugs could be different from adults and is actually very poorly studied and understood. There's also different side effect profiles of some of these drugs, and this largely can relate very easily to things like the availability of, for example, MMF and mycophenolate MPA levels, which in adults have been defined, but again, it's unclear if the same trough levels would actually have the same efficacy or indeed have greater toxicity in children. So therefore, it is unclear if we should be really targeting similar drug levels for some of these agents in children and adults. There's also a potential of altered immunogenicity in these children. There's been thought that that a young child could have a heightened early immune response, but it is also possible that there's a dampened late immune response in infants. In fact, there are studies that I had done at Stanford with Dr. Salvatierra, where we had looked at the transplantation of an adult-sized kidney into a young child, and in fact shown that immunosuppression early has to be controlled really tightly because of a higher rate of acute rejection. But later on, in fact, these patients have the longest graft survivals when we looked at data in UNOS. So again, how the immune response has to be handled in a child can be quite different in how we actually manage it in an adult. Of course, our biggest problem in a in a pediatric patient is as they approach adolescence, and of course then the issues of non-adherence. And we really do not have appropriate immunosuppression that can deal with the issues of immunosuppression non-adherence. So if you look at the immunosuppression combinations that our patients face in our transplant programs, and this is serving pediatric transplant programs in the United States, and it's probably quite similar worldwide, you can see these combinations consist of probably over 60 or maybe even more immunosuppression combinations that a child faces at around the time of transplantation. And of course, many programs will either have induction or no induction. Some of these are based upon fiscal pressures within the program. The other is just upon cultural pressures or on the kind of patient there is. And some programs have very highly sensitized patients and therefore will use a lot of antibody induction. Okay, sorry about this. Trying to get used to this the slide deck. So the induction choices that face patients are actually not just unique to pediatric patients. Of course, they're also the same kind of induction choices in adults, but the utility of those induction choices can be quite different, and their usage. So IL-2 receptor monoclonal antibodies, there was a time when daclizumab was available, and it was extremely popular. We were using it, in fact, for a 6-month therapy over a 2-month induction therapy for steroid avoidance. This showed high safety and efficacy, but because of loss of daclizumab to transplantation in the IV formulation, it's basically been replaced by basiliximab as the main IL-2 receptor monoclonal antibody, which has not been utilized or shown to be safe for longer induction dosing. Daclizumab is actually available in a subcutaneous formulation for myeloma treatment, but despite attempts by many of us to approach these manufacturers, it is still not available as a subcutaneous formulation in transplantation for induction. So it's pretty much been lost to us in transplantation. Thymoglobulin is used for the highly sensitized patient. It's actually got high efficacy and, in fact, used carefully with immune monitoring and with 4 to 6 milligram per kilogram dosing is actually fairly safe. We use it fairly frequently, as I said, for the highly sensitized patient, but also in patients with DGF, and also for rescue treatment for and antibody-mediated rejection or very recalcitrant mixed T-cell and antibody-mediated rejection. And of course, in high-risk steroid-free patients, and since daclizumab is now no longer available, most steroid-free protocols in children are actually using short-dose thymoglobulin for induction. Campath has been used in very few programs for children. It actually results in substantive leukopenia, which actually persists for far longer than we see with thymoglobulin. And this increases the risk of infections, in, especially as we discussed earlier, in the virally naive pediatric patients. And so therefore is not used extensively in pediatrics. Rituximab is really used for rescue treatment, for treatment of, again, recalcitrant rejection that may have antibody-mediated rejection as well as maybe B-cell infiltration-dense rejection. It has been used for desensitization protocols for sensitized patients, but in fact should not be used for induction per se. In fact, there is an article in the New England Journal that came out many years ago where utilizing rituximab and thymoglobulin, in fact, led to very aggressive rejections, potentially because of depletion of regulatory B cells. So it is not for standard induction, but can be used for desensitization prior to transplantation or for treatment of high-risk rejection post-transplantation. Newer drugs such as belatacept, CD40 monoclonal antibodies, IL-6 receptor monoclonal antibodies are drugs that are predominantly used in adults. And in fact, there is very low utility of these drugs in children. Specifically in belatacept, it's associated with a high risk of infections as well as intracranial complications that can be related potentially to EBV, and thus, in fact, it is contraindicated in the EBV naive recipient, which in fact a lot of pediatric patients would be. So as a rule of thumb, induction in children, if in the unsensitized primary low-risk patient, these patients usually either require no induction, they should be given non-depleting induction for minimization protocols, and depleting protocols potentially for some very aggressive minimization, which is actually extremely rare. And in fact, in trials that were done through the clinical trials of organ transplantation in children in the United States through the NIH, in fact, some of these depleting protocols for aggressive minimization have actually not shown success and have been shown to have higher rates of acute rejection. So therefore, our paradigm for the unsensitized primary low-risk patient is either no induction or non-depleting induction. In a very sensitized high-risk patient with high panel reactive antibodies, these are usually either prior transplants, patients with repeated blood transfusions, etc. Depleting induction is used. Again, T-cell induction is mainly used. B-cell induction will usually follow for desensitization purposes. So it's really pre-induction. And then again, high-dose IVIG plasmapheresis, again, are used for preparation of the patient for transplant. So really for the process of desensitization. So let's move to chronic immunosuppression after maintenance. And chronic immunosuppression, we will see that almost all of it in the 2000s was steroid-based. This over time has moved to either an early steroid removal or complete steroid avoidance. And so about 40% of actually patients in about 2020 in the US are facing some kind of either rapid steroid removal or complete steroid avoidance protocol. So you can see that this is basically the utility from 1996 to 2000, and you can see the changes that occurred with cyclosporin being replaced more by use with tacrolimus or FK506, and again, similarly, azathioprine in the yellow bars being replaced more with MMF and in the anti-metabolite drug of choice. But steroids kind of still remain the mainstay of treatment despite protocols that have shown effective steroid avoidance or elimination. So I'm just going to share some of the attempts that have done in the more prospective, randomized, or controlled trials that have dealt with either steroid withdrawal or elimination. I just wanted to share, this is a trial from many years ago now. This is the CCTPT SW01 steroid withdrawal trial in children. This was a randomized controlled double-blind trial of steroid withdrawal in primary living donor or deceased donor pediatric kidney recipients. Initial immunosuppression consisted of an anti-IL-2 receptor. This was basiliximab, prednisone, rapamycin, and then either tacrolimus or cyclosporin for 6 months. These patients were then randomized to either a prednisone taper to 0 versus daily low-dose steroids if the biopsy was negative for rejection at 6 months. So therefore, they all had prednisone for the first 6 months and then randomized. Incidence of rejection was about 8.6% at about 24 months, but there was a high incidence of PTLD. You can see this is quite unacceptable at 12% in the young infant that is under the age of 5. And if you go back, this is basically related to the aggressive immunosuppression of having an mTOR, a CNI, prednisone, as well as, even though this was non-depleting induction, this was significant. So in conclusion, the IL-2 receptor antibody, steroid, CNA, and rapamycin was too immunosuppressive in this at-risk population, and this protocol was abandoned. The other protocol that we used that was pivoted out of Stanford was the complete steroid avoidance protocol. In here, this was again based on the fact that patients were exposed in the SNS01 trial, which actually enrolled from 12 pediatric kidney transplant programs in the US as well as Canada for 120 patients. And you can see that this was steroid-based versus steroid-free as the randomization. Patients received either 2 months of daclizumab in the steroid-based, which was standard, versus 6 months of daclizumab in the steroid-free group, which was the extended daclizumab usage. And then all patients were on the same immunosuppression, which consisted of tacrolimus and MMF maintenance therapy. So people on the steroid-based arm would land up with 3 drugs, steroids, TAC, and MMF, whereas patients in the steroid avoidance arm would actually land up with just 2 drugs, which is TAC and MMF. And I know that Dr. Bagga has had experience using this protocol with some success. So if you actually look at the drugs that we're talking about today, there is a graveyard of actually transplant drugs that have been tried and actually not made it through various clinical trials. And unfortunately, daclizumab, which showed a wonderful efficacy in this study, as well as also, in fact, for repeated monthly immunosuppression for some of our patients with non-adherence, because of problems with the way pharmaceuticals companies actually handle ownership of these drugs as well as manufacturing of these drugs through no fault of its own and not due to lack of efficacy of this drug. Daclizumab, unfortunately, also shortly joined the graveyard of these drugs and in fact is no longer available in transplantation. But I'd like to just briefly run through the slides to show you that actually this approach of steroid avoidance works extremely well if there is effective induction. So even though daclizumab is no longer available, this has been replaced with just thymoglobulin induction of 4 to 6 milligrams per kilogram. And in fact, till today, actually at Stanford, most pediatric patients are completely steroid-free, and the induction is thymoglobulin. In other centers also where the complete steroid avoidance protocol with maintenance of patients just on TAC and MMF is continued, patients are receiving induction with thymoglobulin. So this is still possible to continue. If you look at this, complete steroid avoidance actually shows excellent graft survival. This is data from the randomized study, and you can see on the top is the steroid-free, below is the steroid-based. One of the concerns was, will going steroid-free increase the risk of fibrosis in the graft? And in fact, the data from these studies also showed that when we did serial protocol biopsies, in fact, patients in the trial had engraftment biopsies at 6 months, 12 months, and 24 months, and then another one at 36 months. We found, in fact, that there were similar types of interstitial fibrosis and tubular atrophy that evolved in these patients. And the biggest impact and the driver of what drove fibrosis in these grafts was not if you were steroid-free or not, but was just the impact of time. So these grafts basically show injury over time, but it was not related to whether you were steroid-free. The biggest benefits that we did see, in fact, this was a little surprising, but you could see that there was, in fact, creatinine clearance was similar, though, in fact, in some of these early studies, in fact, showed an improvement over time. And we believe that some of this benefit that we see in graft function over time in the steroid-free could be related to the fact that they actually had less hypertension, they had less hypercholesterolemia, and in the randomized SNSO1 study, we found that they had equivalent levels of acute rejection. The Stanford study actually showed a benefit in acute rejection. So the reason we actually designed the study was for this is actually to show the big impact on growth. And you can see that in the steroid-free arm in the light blue, you can see that the change in percentile height, especially for the under 5-year-old, is substantive. And for the first time, we're actually allowing these children to actually show a gain. And you can see this is the Z-scores that are shown in the lower graph here on the y-axis with the months post-transplant. And you can see up at 5 years post-transplant in the pink and steroid-free, these children are now growing at a greater pace than their age-matched peers who are actually healthy. So showing that the potential for catch-up growth is huge if we actually can give these children a well-functioning kidney, and we can avoid giving them a lifetime of maintenance steroids. This also has big impact for the adolescents. So these children have probably finished their growth, but you can see that the impact on improvement in hypertension, you can see again in the steroid-free versus the steroid-based arm. So you can see in the steroid-free arm, there is a rapid reduction in the need for hypertensive agents, whereas you basically have pretty much the exposure to some antihypertensive therapy post-transplant in the steroid-based patients. And lower, you can see that months post-transplant, you can see the percentage of patients that actually had hypercholesterolemia is again significantly lower over time. And you can see there's a stabilization of effect between 6 and 12 months. The big difference between seen is between 0 and 6 months, when the steroid dose is probably the highest in the steroid-based patients. And then the whole issue of non-adherence is partly related to how a teenager perceives that they look like in the mirror. And you can see here is one of our steroid-free patients who actually, her make-a-wish was to go to Vegas and meet Celine Dion. And you can see here, she looks absolutely beautiful standing next to her, with no evidence of the Cushingoid features that can occur due to chronic steroid exposure. So steroid avoidance in children, just to summarize, I think it is completely possible. It was effective with Occlusa. It is also effective with short-dose thymoglobulin. It's very important for the take-home message is that effective induction is key. So as we talk about in which cases has it been successful, it's been successful with extended Occlusa, not with the 2 months, but the 6 months. It's effective actually with Campath with an acute rejection rate of 9%. It's effective with thymoglobulin. This is seen in children and adults with low acute rejection rates. On the other hand, if you look at the FREEDOM study that was done by Flavio Vincenti, he basically evaluated whether short dose induction would also do the trick. So he used the 2-dose basiliximab, cyclosporin, and MMF, and he did a randomization to 3 arms, maintenance steroids off to day 7, so only for a week, and then no steroids whatsoever. And he showed that in the short dose induction, in fact, patients did not do well. So no steroids whatsoever resulted in a very high rate of rejection at 36%. So take-home message is that you need effective induction. So let's come to the next problem, which is one of calcineurin inhibitor toxicity for the patient. So if you look here, we can see that calcineurin inhibitor avoidance has been tried. This is actually a single-arm pilot trial of CNI avoidance that was done in 35 pediatric living donor kidney transplants. And you can see in this, they did the standard Occlusa. The trial was to use rapamycin and MMF, and then prednisone, which was tapered to every other day. So the trial was to basically give no calcineurin inhibitors whatsoever, and to see if you could do this with just mTOR and MMF. There were multiple biopsies done, and essentially the protocol failed because there was a very high rate of acute rejection. There was a 6% PTLD. There were a lot of complications, and so this was really in children, we basically do not believe that we should be doing a transplant without exposure to some form of CNI agent. Other trials that have tried minimization after transplant, there is a withdrawal trial, which was then withdrawing the CNI after transplantation, replacing it with an mTOR. This was done in adults. There was some improved graft function that was seen. There was some reduced time and risk of skin cancer. But in children, when we actually tried to do this, and in patients that had a lot of interstitial fibrosis and tubular atrophy, there was actually increased risk of graft loss. So it seems that CNI minimization, withdrawal is, CNI avoidance should be avoided. CNI minimization and withdrawal is extremely risky. And there could be a point of no return in the allograft. When you have significant interstitial fibrosis and tubular atrophy, it is possible you may also have chronic humoral changes in that graft. At that point, withdrawing of the CNI actually can accelerate graft failure further. So the whole manipulation of the CNI is extremely risky. The one place that CNI minimization or avoidance has been successful is use of belatacept. As you know, that belatacept has predominantly been used in adults and in fact has fallen out of favor because of the early rates of acute rejection, which were poorly understood, and the messaging was probably not handled well by the company. I personally believe that it would have been a drug that would have revolutionized the way we could have extended graft life expectancy, because the New England Journal trials showed that at 7 years, in fact, patients who were on belatacept without CNIs actually had, for the first time, improvement in graft function over patients who were on CNI, despite the early rates of acute rejection. but the drug has fallen out of favor because of that early acute rejection that occurred that has not been well handled. And as I stated earlier, in children, it's a tough drug to use in the young child and in people who are actually EBV naive, where it's in fact even contraindicated. So really no experience in children. So come to rapamycin or sirolimus or everolimus. So when do we use it in pediatrics? De novo is not supported. Again, wound healing can become a problem. It can also exacerbate delayed graft function, and it can actually cause increasing nephrotoxicity because of its synergism with the CNI agents. MMF and rapamycin alone has a very high incidence of acute rejection without CNI, so is not recommended. It's really used for rescue treatment. If you have early MMF intolerance, which occurred in fact even in the steroid avoidance protocol, MMF was replaced by rapamycin and tolerated well. If early CNI toxicity occurs, not advanced, then a switch very early on can be tolerated. In protocols that use minimization and withdrawal, it can be used as an adjunct. And even though there is this, unfortunately, bad rap of this drug associated with reduced sperm count, we have little or no data on pre and post pubertal males for chronic therapy. So this is, I think, a place that still requires additional research to be done to actually evaluate long-term safety and whether sperm banking or even evaluation of sperm counts is something that should be done in males that are exposed to this for some time. We also look at immunosuppression choices in children and how they influence outcomes for infection and PTLD. This is extremely important, especially in the pediatric patient who is naive. This is just data to show that in the steroid avoidance protocol, again, because the steroids can influence the promoter regions for some of these viral transcriptional genes, you can see that the steroid-free protocol, when we looked at the number of patients that had even asymptomatic subclinical CMV viral replication, that was actually much lower than patients on steroid-based protocols. So manipulation of some of these immunosuppression agents can actually have beneficial effects in that regard. The pediatric challenge also remains one of understanding pharmacokinetics. This differs in children, and in fact, we know that there is a decreased sirolimus and everolimus half-life, that in some of the studies, like the CNI withdrawal studies, there was actually, I think sorry, my slides seem to be jumping. Okay, I seem to be on a different slide right now.
You wanted to go to the previous slide, ma'am?
Yeah, I was on a...
let me move to the previous slide, ma'am. Is this okay?
Yeah, I'm not actually sure where the slides went, but okay. So the challenge for immunosuppression in minimization trials is really one of suboptimal monitoring. If we actually look at these trials and we are trying to address immunosuppression, we look at serum creatinine, which has weak prediction. We look at protocol biopsies, which essentially pick up histological subclinical acute rejection, but they can actually miss molecular inflammation and of course are invasive. And then we have biomarkers that we're looking at UCSF to try and understand how to better monitor our patients. So I wanted to share some research that has come out of work that we're doing in our lab, is to develop a urine test for non-invasive accurate diagnosis and prediction of kidney transplant rejection. We call this test QSANT. Sant is health, and the Q is just for quiescence, or take your Q on rejection. It requires just a 5 ml sample of urine, and we can actually collect the urine from the home of the patient, and then it can be sent to the lab, and you can get a result back in about 2 days, which gives you a score that scales from 0 to 100. This test basically uses 6 markers. We use cell-free DNA in urine is measured. We don't use amplification or sequencing. This is done using a chemiluminescent immunoprobe. We look for methylation of cell-free DNA, which is an epigenetic change of that cell-free DNA. Also look for clustering, which looks at tubular markers. For CXCL10, which is looking at immune infiltrates within the graft, as well as protein and creatinine. All these markers are then put together through an artificial intelligence-based algorithm to actually then create a score from 0 to 100. A score of less than 32 means there is very little or no risk of rejection, whereas a score of greater than 32 means an increasing risk of rejection. And if a score of greater than 35 tells you that there is a very, very high risk of rejection. So this paper was published in Science Translational Medicine last year. It's a multi-center study from 3 centers, 601 samples, urine samples, with 364 samples from kidney transplant patients, each urine sample paired with a biopsy. There was a training set and independent validation set. The assay picks up both T cell and antibody mediated rejection because it is picking up holistic injury within the graft. It's because it has a quantitative score and because the assay correlates with the amount of tubulitis and inflammation in the allograft. So the greater the score, the more the tubulitis, the more the inflammation, it can pick up greater severity of rejection. It can pick up, of course, rejection, whether it's an HLA matched, mismatched, if it's a repeat transplant, or if it's a multi-organ transplant. And this is one of the earliest studies that actually looks at a pediatric population. So adults and children were both evaluated in this, and you can see very strong sensitivity and specificity comparing to biopsy-confirmed acute rejection. You can see that this test is actually currently being used in about 6 transplant programs and expanding rapidly. It was launched in about April 1st of this year. It basically is being used serially to look for patients that actually have little or no risk of rejection, shown here on the left, versus patients that actually you could predict rejection even before it's actually confirmed by biopsy, here on the right. It's the first pediatric transplant program that it got launched in was Rady's Children's Hospital in San Diego. And the principal investigator there is Dr. Liz Inguli. So we are able to use the score to try and evaluate now serially in kidney transplant patients risk of rejection by doing a urine test either monthly or quarterly. And if the score is less than 32, you know that your patient lies on the left, which is in a very low immune risk threshold, whereas on the right, the patient actually will be, if their score is greater than 32 and it keeps rising on repeat scores, as you can see, these arrows show in patients where the score is increasing, you can see that the patient is at higher risk of rejection. And of course, we are able to also start to understand the middle ground, where we are able to repeatedly test the patient and evaluate in real time what their immune response is doing and how their immunosuppression should be dosed, rather than just doing trough levels, which maybe only reflect the propensity of the immunosuppression from the previous 12 hours. I also wanted to show that we are using these biomarkers to better dose our immunosuppressive drugs. This is a trial that we are actually doing through the NIH. It is a U01 trial with Dr. Vincenti as the principal investigator, where we're actually looking at subclinical inflammation in these protocol biopsies. And they're either giving them standard of care treatment, or we're giving them regulatory T cells that are expanded against donor, and then looking at various biomarkers to see if you're actually improving outcomes in these patients. So I just wanted to summarize by saying immunosuppression, minimization, and customization in children is a fine art that most of us pediatric transplant nephrologists have learned to walk the line. We understand that effective induction is going to be key for any kind of minimization that is needed in our patients. We believe that some kind of depot immunosuppression is going to be needed to eliminate some of the daily side effects of the medications and also tackle non-adherence. Belatacept in adults will not be available, I think, in children, unfortunately. Other drugs newer generation drugs will always be tested in adults. Daclizumab actually had a lot of potential, and we were using it as depot monthly immunosuppression in our adolescents effectively, but unfortunately is no longer available. But the subcutaneous formulation may again be available back in transplant one day. Some medications may require time-dependent removal. Calcineurin inhibitors should always be removed or minimized late. RAPA really should not be started too early because of its side effects. And then steroids, we should remove early or avoid altogether. But late steroid withdrawal can actually be quite hazardous. Some medications have to be restricted by viral memory. And we talked about the problems with belatacept. And immunosuppression should be dosed based on serial non-invasive biomarker measurements of immune activation, such as the new biomarkers that are coming out in urine, which could be completely non-invasive. This way we can help to minimize infection and address the problems of chronic graft injury. So I think the day will come, maybe, when immunosuppression will not be needed at all. This is The Economist, which is talking about printing organs. I think we're getting there, and maybe one day we'll be able to print ourselves a kidney or clone the kidney. We're not totally there yet, but we have to keep our eye on the horizon that will come one day. Just wanted to end by thanking all of the people that do a lot of the work in my lab, as well as my collaborators and my clinical colleagues, as well as all of the funding sources that we have from the NIH, as well as our pharma partners. Thank you so much.
Thank you so much, ma'am, for the excellent talk. Your years of research and in-depth understanding of subject was very much evident in your presentation. It was very insightful and inspiring. Thank you so much, ma'am. Can we go ahead taking the questions, ma'am? Bagga sir, you're there around?
Yes.
Okay. Like we have...
yes, Kalevani, yeah.
You're able to hear me, sir?
Yes, I can hear you. Yeah.
Okay. Okay, we'll go ahead with the questions. The first question is...
I can hear you.
Can we have renal limited hemolytic uremic syndrome? Had a child with AKI and repeated renal biopsy reporting TMA. HB NIDER is 7, platelet is 1.2 lakhs, and LDH is max 800. Despite repeated smear exam, no cystiocytes.
So at times, you may not really be able to show histiocytes, but if it's an acute illness, I think as a diagnostic purpose, we should be able to demonstrate broken cells. At times, you get a patient who comes with just anemia or with just impaired kidney functions, and you find evidence of TMA in the form of mesangiolisis or something on the kidney biopsy or arteriolar changes, or just plain fibrin along with mesangiolisis on the kidney biopsy. So maybe this child did have HUS-like illness a few days back, but for an acute illness, somebody who's anuric, who's clearly sick, then I would definitely think that histiocytes should be demonstrable. In the absence of histiocytes, to diagnose HUS would be fraught with danger, Yeah.
Okay, fine. And next question is, what would be the plan of management for a child with malignancy with hemolytic uremic syndrome?
So ideally, it has to be, so there are very few malignancies in children who get, most of the malignancies that cause HUS are really malignancies like colonic CA and so on, so they're not often seen in children. But I would imagine, and I don't have personal experience, but I would think, that it would be good supportive care. There have been anecdotal reports about the use of complement inhibitors. But again, that would be an anecdotal thing, But I would think it would just be good supportive care. I don't even know whether there's a role for plasma exchanges in a major way. But I think that would really be you'll have to probably just provide good, appropriate care.
Okay. Next is a little bit of genetics in it as well. Once incriminating gene abnormality is found by NGS, instead of prolonged expensive complement inhibitors, why not think of gene editing with CRIPCR?
So the CRISPR-Cas thing, we don't have data yet. So these things may happen in the future. And as I said, even if you've got a mutation, even if you've got we don't use the word mutation anymore, even if you've got a pathogenic variation or a likely pathogenic variation, one would be managing these patients with standard therapies. The role of CRISPR-Cas is still, I think it's too early to use these technologies as of now. It's possible in the future these things may come up. But having said that, even once a child has a mutation or a variation, pathogenic variation, one would provide appropriate care. One may have to do plasma exchanges in a country like ours, where you don't have access. But then you can consider stopping this after a few months and continue monitoring these patients for relapses. It's not as if you need to carry this on forever.
Okay. And so the next question is to Sarwal ma'am. Madam, you're there around?
Yeah.
How risky is blood transfusion for sensitization?
It depends. If it is before transplantation, of course, a transfusion will cause sensitization. And if it is after transplantation, once immunosuppression has started, then blood transfusions actually do not have the same risk. So it depends on the timing.
Okay, fine. And the next question is again to you, ma'am. Like, what is any study about steroid-free regime in GN?
Well, yeah, I mean, so we have, I think there's quite a few publications. There is the original experience that came from Stanford. And then there is the steroid, no steroid trial, SNSO1 trial that was published in the American Journal of Transplantation. That has, I think, 3 papers associated with it. I think it's all 3 papers in the same issue of AJT. And I think in PubMed, you could find them under my name. But the first one is about the clinical trial results, some of which I showed. The second is about the largest protocol biopsy series, which I hinted at that they don't have they have equivalent acute rejection, and the biggest impact of fibrosis in these patients was just time, not the absence of steroids. And the third paper on this trial is about antibodies. So we showed that donor-specific antibodies to HLA and MICA, and these studies were done by Paul Terasaki, showed that you basically had lower rates of antibody generation in people who had steroid avoidance versus steroid-based, so showing again the safety of steroid avoidance.
Okay, thank you, ma'am. The next question is to Bagga sir. We have a 5-year-old male child with B-cell ALL on day 23 of consolidation phase, now with diarrhea for past 5 days, AKI from 2 days, anemia and thrombocytopenia from today. HUS received HUS. It is a HUS query HUS, and child has received 6 doses of methylprednisolone, cotrimoxazole in this phase. Kindly suggest management in such child with secondary HUS.
So what is the cause for secondary HUS? Yeah, so they're saying the patient had a B-cell ALL.
B-cell ALL.
B-cell ALL. And how old is the patient?
5 years old.
So, and there's clearly no septicemia. There's no sepsis.
There is no sepsis. The child has already received methylprednisolone, and the child is on cotrimoxazole. Yeah, sir.
And why methylprednisolone? That's not the standard therapy.
Yeah, that's what the child has received. That is a standard treatment for probably for B-cell ALL. I'm not sure, sir, but
really. I didn't know that. Yeah. So, even the standard malignancy drugs, they don't normally cause HUS. So, I would just like to be sure, that this is really HUS before you. A leukemia could have a bone marrow suppression, anemia, thrombocytopenia. AKI could have multiple reasons. Because this combination seems a bit odd. So I'm not sure, but because we're not really, encountered this, it would be odd to get this combination because I hope the anemia, thrombocytopenia is not due to the leukemia per se, rather than due to HUS, because it would be, because on the contrary, if a child does if this happens, and if this is an acute infection or whatever, he got Shigella and then he got HUS, then again the therapy would have to be supportive. I would be cautious doing anything more aggressive than this, because doing plasma exchanges, etc., would have no meaning, honestly, for a situation like this.
Probably this. Yeah, sir.
Yeah, sorry, Kalavan. Yeah, you were saying something. Probably what?
Probably this anemia thrombocytopenia is associated basically because of B cell ALL rather than HUS, a new diagnosis, sir.
It would be yeah, it would be extremely odd to have a new disease totally coming in, and
Okay.
you. I think at times, when there's a dilemma for intravascular hemolysis, doing a plasma haptoglobin is a good idea because if you really have significant intravascular hemolysis, the plasma haptoglobin levels should be almost undetectable. They would be very, very low. So at times, we have this doubt. So number one, show cystocytes on the smear, have a high LDH and a low plasma haptoglobin.
Okay. Okay, fine. So we'll move on to the next question. Anti-CHF antibodies mediated atypical HUS, is genetic test will change the management?
As I said, in anti-FH associated HUS, the commonest underlying genetic anomaly will be a homozygous deletion of CFHR1. That does not change the management. That would be seen in almost 90%, 85 to 90% of all patients. The basis why it happens and why it causes antibody generation is not clear, but overall that does not change the management. Now, do patients with anti-FH associated HUS require clinical exome sequencing now? As I showed you that forest plot, about 5% to 6% of patients would show a pathogenic variation in other genes. That would change the management, but generally speaking, we do not advise doing the test because the likelihood of picking up another associated anomaly would be extremely uncommon. So mostly we would not do a genetic study. We would do a genetic study only if the child is very young or if he's having a relapsing disease and so on, or if you're planning a transplant. So mostly it's not required.
Okay, okay, fine, sir. Next question is to Sarwal ma'am. Is it correct that early steroid withdrawal, that is in the first 3 to 5 days, is better than late steroid withdrawal, that is 6 months, in terms of AR incidence, abdominal long-term graft function? What is the current protocol in your institute?
Yeah, so I think that is correct. If once there is long-term steroid exposure, we believe that there's probably many axes of the immune response that actually get suppressed, and then withdrawal becomes quite difficult to predict which patient is going to be successful. So it's there'll always be anecdotes that somebody withdrew steroids and they withdrew it slowly and it was safe. But in the general rule of thumb, it's very difficult to predict who's going to be safe. So our recommendation is that if you're on chronic steroids, then you should minimize over time. If a patient is having some side effects, on 5 milligram maintenance, you could potentially try and wean down to 4 or 3, but we would not recommend complete withdrawal. But if you're actually looking for withdrawal, then early avoidance or early removal is the best. There are many protocols where thymoglobulin or depleting induction is given for 3 days, and of course steroids are given as a pre-med with it. And then once this thymoglobulin is over, there's no more steroids, and patients actually tolerate that very safely. So yes, earlier withdrawal is safer than later withdrawal generally because it's more applicable as a protocol than late withdrawal. Our protocol is basically to use low-dose thymoglobulin, 3 milligrams per kilogram we actually use now. We've come down to that. And then use low-dose steroids just for the pre-induction for the thymoglobulin. And then essentially they're on TAC and MMF maintenance.
Okay, ma'am. The next question is again to Sarwal ma'am. Leukodepleted blood or irradiated blood, which is better in renal transplant?
So leuko-reduced definitely, because you're trying to minimize the burden of HLA that you're giving, which is really on the white cell component. So leuko-reduced is really, I think, more beneficial if you're trying to minimize the risk of sensitization.
Okay, and the next question is again to you. Hope you don't mind taking questions, ma'am, because we have exceeded time.
It's okay.
Okay, the next question is, in your center, are you using more of ATG as induction agent more than basiliximab, and how is the experience there?
Yeah, because we actually try and do more of the steroid avoidance. So for steroid avoidance, basiliximab is not recommended. Because for steroid avoidance, as we talked about, you need effective induction, and just the 2-dose basiliximab, as I also showed you in the Vincenti study in the adults, does not work. And so for that reason, we use more ATG because we are trying to do short dose ATG with steroid avoidance. So for that reason, we use more at our center, correct?
Okay, fine, ma'am. Probably the next question is to Bagga, sir. This eculizumab will be useful and prevent the progression of CKD in anti-CHF antibody-mediated HUS during remission phase.
There's no data, and I don't think we need to be in a patient who's in remission. I would just monitor the autoantibodies. If he gets an infection, be aware that a relapse could happen, and we may have to take action. But clearly, there's no indication to be using eculizumab in during remission in anti-FH mediated disease. I know that people in the developed countries, there has been a tendency to give prolonged eculizumab for long periods of time. But even there, as I showed you data from at least 2 studies that would suggest that one can start considering taking off eculizumab. So the role of eculizumab is chiefly to prevent, to induce remission and to prevent acute disease. Long term, to prevent chronic kidney disease, etc., is the role would be extremely limited, especially in the setting of anti-FH associated HUS.
Okay, fine, sir. The next question is again to Bagga, sir. Using fresh frozen plasma for treatment of factor H deficiency in atypical HUS, is it okay? During clinical HUS active for factor supplements, if eculizumab needed to import or unavailable.
Yeah, so we don't have access. So if you've got an acute disease with with the complement factor H pathogenic variation, I think I would probably do plasma exchanges rather than giving plasma infusions. The advantage of plasma exchange is that you can give much more plasma. You can give up to 60 mils per kg of plasma, which you can not give otherwise. It's also said, that at times the factor H variation produces factor H products that are there, but which are, abnormally shaped and so on, which may not really be the right morphology. So you need to remove that factor H, which is perhaps dysmorphic, if you could say that word, So you are able to remove the not appropriately formed factor H molecules and perhaps replace with factor H. So I would definitely consider doing plasma exchanges acutely. After a few plasma exchanges, one can then shift them to plasma infusions. But even there, one can do plasma infusions every 2 weekly or after every 10 days. 10 days is usually the time, 10 to 14 days. And consider, stopping. You may not be able to stop in all patients, but for the acute stage, I would definitely prefer doing plasma exchanges and not plasma infusion alone.
Okay, so next question, I think it is again a repeated question to Dr. Sarwal, ma'am. How bad is blood transfusion for sensitization? Would you like to add on something, ma'am? I think you have already answered the question before.
Yeah, I mean, blood transfusion is one of the risk factors for sensitization. Leukoreduced packed red blood cells will minimize that exposure to HLA sensitization, but it is definite risk factor for sensitization. So we always check for panel reactive antibodies in these patients that have had transfusions. An occasional transfusion may not mount a robust sensitization response that's long lasting. But it is a risk factor. So we do see it, and especially the HLA sensitization increases if there are multiple blood transfusions compared to a single. And as I said again, blood transfusions after transplantation, when they're on immunosuppression, is not a risk factor because you don't mount the same immune response.
Okay. We are done with the questions, ma'am. Thank you so much. Thank you, sir. Both of your talks were made us glued to our seats, and thanks for sparing the weekend. And anyways, we have exceeded the time. Thanks for sparing your weekend, ma'am. Thank you so much. Thank you so much, sir.
Thank you. Thank you so much.
Thank you. Bye.
It was an excellent webinar today. We had a real great time with a lot of knowledge, and thank you so much. But sorry for the technical issues.
Not at all.
Thank you, sir. Thank you, ma'am.